Are we live? Yes. Okay. Well, good afternoon, everybody, and welcome to this meeting of the Integrated Care Partnership. I'm Councillor Jonathan Owen. I chair the East Riding of Yorkshire's Health and Wellbeing Board, but also Vice Chair of this partnership. So welcome to everybody. I'm going to go around the table in a second, but a particular welcome to Alison Barker, 6 weeks into her role as Chief Exec of North Lincolnshire now. So welcome, Alison. And I think now I'll go around the rest of the table so people can introduce themselves, particularly for the benefit of people that might be watching live, because we are being live streamed and this will be recorded, just so you are aware in the comments that you make during the course of the afternoon. So thank you. So Sue, I'll pass to you next. Thank you.
Good afternoon. My name's Sue Symington. I'm Chair of the Integrated Care System.
Hello, I'm Simon Cox. I'm the NHS Place Director for the East Riding and the ICB.
Hello, I'm Wendy Balmain. I'm the Place Director for North Yorkshire.
Sarah Coltman-Lovell, Place Director for York.
Hi, Helen Kenyon, Place Director for North East Lincolnshire.
Jake Abbas, I'm Deputy Director for Population Health Intelligence with the Integrated Care Board.
Hello, I'm Mike Napier. I'm Director of Governance and Board Secretary for the ICB.
You introduced me, so thank you.
Hi, Alex Seal, North Lincolnshire Place Director.
Hi, I'm Vicky Lowe. I'm the Head of Corporate Affairs and System Support for the ICB.
Hi, Councillor Stan Shreve, Deputy Leader, North East Lincolnshire Council.
Linda Chambers, Chair of Health and Wellbeing in Hull and also portfolio holder for Adult Services and Public Health.
Hello, Erica Daly. I'm the NHS Place Director for Hull.
Good afternoon, Pete Thorpe, Executive Director with the ICB.
Steve Neames, Chief Exec of the ICB.
Thanks very much, everybody. And in the spirit of true integration between local government, partners, NHS and everybody else, I'll be taking the first 10 items, I think, on the agenda, and then I will hand over to our Chairman, Sue, for the remaining items. So no further ado, we'll crack on with apologies for absence, and I have got Helen Grimwood, Amanda Blower, Louise Wallace, Alan Menzies, Matt Dukes, Rob Walsh, Rob Waltham, Richard Flinton, Ian Floyd, Julia Weldon and Charlie Jeffrey. And we have 3 councillors joining us on the screen, so who'll be taking part. Did you want to introduce yourselves out there at home or wherever you are, just so everybody's aware who's there? Joe, shall I start with you? Thanks. I don't know if you're on mute or whether we can... Thanks. No. No, we've no sound at this end at the moment. Michael, should we try you?
Try me, Councillor Michael Harrison. I'm Councillor at North Yorkshire Council, Executive Member for Adult Services and Chair the North Yorkshire Health and Wellbeing Board.
Okay. Thanks, Michael. Richard, I'll come to you
Hello,
next.
Jonathan.
Thanks.
Not at home at all, miles and miles away, in fact, 270. Councillor Richard Hannigan, Deputy Leader of North Lincolnshire Council and Cabinet Member for Adults and Health.
Welcome. Joe, try you again. Yes. Sadly, still can't hear you, but wave violently and we'll try again if anything crops up and you want to contribute. Okay. So thank you for that. Let's now move on to any declarations of interest, and that's any declarations on any item on the agenda. The meeting members are reminded to declare any interest relevant or material to the ICB, and then the nature of any interest declared, financial, professional, personal or indirect, and any changes in interest previously expressed. No? Okay, thank you. So we shall now move on to the minutes of the previous meeting held on the 20th of December 2023. Are we happy? Those that were there, they're a true record. Thank you. And then any matters arising and actions. I think there were only 2 actions arising, unless anything hopefully will be covered further on in the agenda if there's anything else. But those 2 items were 1, an update regarding health and care place committees will be brought to the next ICP meeting in March, but I think that's going to be incorporated into the Chief Operating Officer's place report, I understand. So we'll touch on that later. Thank you. And also Health and Wellbeing Board outcomes from Northern Lincolnshire will be brought to a future integrated care partnership meeting for discussion. Alex, have we an update on that?
Yeah, so just contextually, we were hearing about some of the engagement approach. I think it was Councillor Hannigan who raised the point, with an opportunity to share some of that. So I think that's something we'll be building into the future ICP programme. So when we talk about the item on the framework, I can pick that up as well.
Okay. Yeah. Richard, did you want to comment at all?
No, I think Alex has covered that absolutely fine. Thanks, Chair.
Okay, thanks very much. So now I'm not aware of notification of any other business at this point, so we could move on to the Integrated Care Board review. Sue, I'll hand over to you.
Thank you, Jonathan. As you know, both Jonathan and I seek to provide a little pen sketch at the beginning of this meeting of what's been going on in the Integrated Care Board, and in turn we feed back to the Integrated Care Board about things that have been going on in the Integrated Care Partnership. So it's just to make sure that there's a read across between the two. We last met on the 20th of December. We were in the very midst of winter, weren't we, at that point, and we were wondering what was going to happen next. So you can imagine that the last 3 months, certainly December, January, February, were very much dominated by performance across our system. That was the thing that people were talking about. We worried about patients with no criteria to reside. We were worried about ambulance waits. Worried about how long people had to wait in emergency departments. So a very performance related period for us. We had junior doctor strikes, as you know, the longest strike in February. Our organisations are well prepared now for strike action, so we found our way through that, but hugely disruptive and of course unhelpful to patients, because anyone who was waiting before then finds themselves waiting a little bit longer again. So that was the first few months of the year, and subsequently we've been talking a lot about the money, where we're going to land with our accounts at the end of the financial year, and what our plans are going to be for the year ahead in terms of our the budget we need to work to, and how we're going to ensure that we're productive enough to make sure the money we're given is enough to deliver all those things we're required to deliver. So we've been through quite an intense period recently, looking at our financial position, looking at our productivity, and working out how we can attempt to live within our means in the year ahead. I think this is akin to local government partners who've also been facing financial challenge too. In a nutshell, those are things that have concerned the Integrated Care Board. And as we're fortunate enough to have our Chief Executive sitting just 2 people along from me, I wonder, Stephen, if you think I've missed anything critical that you'd like to mention over the course of the last 3 months that might be useful to the Integrated Care Partnership.
No, not really. I think it's probably worth just noting a couple of things. Just linked to the performance agenda, despite all that pressure you alluded to, and the and the strike action and so on, it's really quite remarkable that this system will deliver its elective target for routine operations, apart from 18 highly complex cases. I think that's well worth noting.
Yes, yes.
We also will deliver our cancer backlog target, and at the same time we're about 20% above our faster diagnosis target in cancer services. I could say some other things, but I just wanted to flag those two. I think it's also important to note that, to quote our finance director who's not here, we've landed our financial plan on a postage stamp, so our target as a system was a 13 million deficit, and that's what we're going to hit there or thereabouts, which is also, worthy of mention. The other thing that I think is worthy of mention, I can't remember whether it's been picked up here before, but we did approve at our last board meeting. I mean, 2 things we approved actually. One was the policy and process for integrated working in North Lincolnshire Place. Helen's here, so people can chat to Helen if they want to know more about that. But I think that's signalling the direction of travel for all of our places quite rapidly. I think that's quite an important step. And I think the other thing I would mention is what we touched on in these some early meetings here today, that our Futures group, that shared by Charlie Jeffries, the Vice-Chancellor at York, signed off a really significant programme of work around children's services, which is aimed at trying to move us towards, it's not the only thing, but to give us, if you like, a foundation stone for generational change for children. So those are things, I'd just add those two things that were probably quite important in the last few weeks. Thank you.
Good, thanks. Any questions at all for Sue at this point? No? Okay, we shall move on then to my brief summary of position with local government. What I've tried to do is distill some issues particularly pertinent, I think, to our relationships across the partnerships here, rather than, you know, state of play in local government generally, which we could spend all afternoon on, I would think. But so I've had a couple of discussions. I'm hoping I've pulled out some things that will be of common to all the 6 places. We've got them all represented by elected members here today, which is great. So please, at the end of it, feel free to chip in with anything I may have missed or anything you feel strongly about. That's to my invitation to my elected member colleagues. But I think some of the points from discussions I've had over the last week or so, I've tried to bullet point them. And first of all, actually, just coming this morning, the first thing I picked up in the Yorkshire Post this morning was, you know, 2 of the things I was going to raise anyway. First of all, it's ministers failing to fix the social care crisis. And then at the bottom of the page, pharmacies facing tsunami of closures, both of which were on my bullet point list anyway. I don't think the social care one will surprise anybody, because that's an issue I know we've been talking about for many months. But I think some of the things behind the scenes that are going that I think affect us all across the system, first of all, an increasing levels of these multiple morbidities, which are making sort of the community and acute management of ill health episodes far more complex to treat. And I think they're on the increase is the message that's coming through. And of course, these patients then with delays in getting treatment, etc., then reducing the capacity in the system for discharge, because the longer they're waiting for treatment, and we've got quite a few cases of people taking 60, 90 days before they get treatment, and of course they're getting worse while they're waiting for that, and this is creating problems in the system. Also, an increased numbers of working age people not working because of long-term illnesses, and in particular poor mental health linked with uncontrolled chronic health issues as well. And that's featuring, I think, and I'm sure that'll be across the 6 places and not just in various places. We've talked about the pharmacy market potentially shrinking. Parochially, we've got issues now for the first time in my probably 15, 20 years involved on the health side of things in the local authority. You know, the pharmaceutical needs assessment was always a straightforward thing, and it was a box ticked every now and then. We are now finding issues. Right. And although local government, we're not responsible for the provision, but through Health and Wellbeing Board and certainly through our Directors of Public Health, we have a responsibility to highlight where those shortfalls are. And similar problems, which we're all aware of, with access to dental services as well. But again, that's been well rehearsed, I think, in the various ICB and ICP forums. I think there's also the consequences on the cost of living impact on health and the risk factors, housing, food, debt, transport, and this is having a knock-on effect to those people who are caring, many of them caring for their own families. So I think there's a pressure, both financial on some of the people that historically have cared for others, and also finding it harder to live with some of those longer-term conditions, particularly if you haven't got access to pharmacies and get support at home. That's going to have a knock-on effect, I think, on pressures into the health system. I jotted down here, and I bet I should be quoted on this, the reluctance of government to pull some of these national policy levers to have an impact upon diet, food, drink, etc. I think for a long time we've talked about, you know, obesity strategies, inequality strategies, and these seem to have been delayed or shelved. And that's probably criticism of my own government, so I've got to be careful actually how I put that across, but it's worth saying. Some good news on the smoke-free stuff. We just have to get that sort of legislation through Parliament, so that needs pushing and hope will go through. And also, It was interesting, the other day I got picked up, we have in local government, and some of you may get it, the Local Government Information Unit, which does daily bulletins on local government issues, and particularly the County Councils Network that came up with the figures at the moment, the research that compared with a decade ago, the average amount of money that comes from an individual's council tax used to be for children's services was £100 a decade ago. It's now £212 as a proportion of your council tax in 10 years. And adult social care costs have risen from £252 from your council tax to £373. So particularly in the county councils, the unitary authorities and Met authorities, about 2/3 of all their expenditure is now going on social care and children's services. I mean, parochially and anecdotally in the East Riding, we're going to have an overspend on our budget this year of about £11 million on the social care budget. And, you know, and that's on a total budget of just over £300 million. So and that's an overspend, which will have to be carried forward and managed. So the net problem with that is that councils will start cutting back on those non-statutory services. So that's libraries, open spaces, parks, anything that's non-statutory will start getting cut back on. And I think that's going to accelerate probably over the next year and 18 months as people struggle to make ends meet. That's the bits related. We've still got the issues in trying to make the social care workforce something people want to go into. There's a lot of evidence about now that post-COVID, a lot of people have now retired from the workforce. The stress and the pressure of doing that has made them retire early and move on. So we're still trying to do a lot of work, and I think it will be across all our 6 places to encourage people to see social care as a proper career and not a second-rate function. And all we can do jointly, I think, to push that can only be for the better. So that's the bits related probably to social care and local government, but of course politically, and that's across all parties, we've got a general election coming up, we've got local elections coming up. Either some of us have, some of us haven't, some are in thirds this year, but a lot of, I don't know, well, a lot of concern amongst all parties as to what the outcomes are going to be, I think, particularly the local elections, because there are so many unknowns about at the moment. And I think nationally and probably government-wise, people are sort of going into their own boroughs and not realising some of the actual impact that's happening on the street at the moment with people. There is a lot of disillusionment around, in my mind, I think, and I would not, for the first time in all my years as a councillor, would not like to put any money on what I think the outcomes are going to be, because we saw those of us last year sort of suffered lots of new members, lots of members retiring, and lots of people not wanting to come into government at all levels. And I think it's not a career, isn't local government from an elected member, but I think there's not a lot to attract people at the moment with the sort of publicity we get nationally and locally. So, of course, we're going through North and South Bank, various mayoral devolution deals, so the outcome of that is going to be interesting. I mean, York and North Yorkshire obviously well down their route for May elections this year for that. North East Lincolnshire and Lincolnshire have now just about gone down the route there. I'm looking at Stan here and Richard, because I think their cabinets and councils have agreed that moving forward.
Absolutely. There was a ceremonial signing by a government minister some weeks ago, but all 3 top-tier authorities this week, through their full councils, have approved the Greater Lincolnshire devolution deal.
Thanks, Stan. And, of course, Hull and East Riding are waiting the feedback from their consultation exercise, which is imminent, if not certainly the next week or 2, I should think. I'm not quite sure where we are with that, but it's not far off, I know, so we'll see where we go from that. So really, that's it for me. It's a bit negative, I'm afraid, but, I mean, they're all issues we're all aware of. And I say we go through cycles with a lot of this, you know, and funnily, you know, in a year's time, we suddenly seem that we're all still there somehow, you know, whereas you think at this moment in time it's all gloom and despondency, but it isn't, because there is a lot of good work going on behind the scenes, on the ground, particularly in social care and the health service. I think sometimes we need to flag that up as well as some of the problems and issues. So that's my brief summary. I'm happy for anybody else to chip in, my colleagues either on the screen. Stan?
I'd just like to put a ray of sunshine into what was a pretty negative summary. You're right. I mean, in terms of the cost of social care in all of its forms, it's not a surprise that it's 65% of our budget as well. It's a big number. But I think we're confident that, certainly in North East Lincolnshire, that our grip is quite strong and improving in those areas where we have been weak. And to give you a couple of examples, I mean, 12 months ago, as a relatively small place, we had 620, I think, looked after children. There are now 460 looked after children, so that's definitely coming under control. In terms of adult social care, which is our big beast budget, that is not overspent this year, and it is not likely to be overspent next year, fingers crossed. And the strategy is being reasonably effectively employed and deployed behind a high level of integration within our place, to the extent that we are much more tactical now in the way that we develop. For instance, we're trying to skew our fee increases towards keeping people safe in their own homes. So if you're a provider of domiciliary care in North East Lincolnshire, you'll get a higher increase this coming year than if you're a care provider. And we see that as a strategically important place to go. Elsewhere, the level of integration that we continue to enjoy is quite impressive, but fatigue does set in from time to time, and we've noticed on our Health and Wellbeing Board that some of our more extended stakeholders sometimes find it difficult to attend every meeting, but I forgive them for that because their spirit is willing. In terms of elections, we're about to enter that wonderful period called PERDA, which is a combination of nothing happening and not very much happening. But of course, it's a good time of year for all councillors who are part of an election process to get really fit and healthy with the hundreds of miles that we walk, posting leaflets and knocking on doors. And it's a really great way of developing our social skills. And I have to say that in my years of being a councillor, I'm sure you might have experienced this, it's very, very rare that people are abusive to us on the doorstep. Yeah. Almost doesn't happen. People are generally very well behaved, aren't they? And the only question I've learnt to ask, and I'll finish at this point, is if the person who opens the door to me is apparently under 25-year-old, then the first question I ask is, are you registered to vote? Because there's a fair chance that they're not, unfortunately, and I think that is something that as a nation we have to really concentrate on. And at which point I say, I encourage you to register to vote because it's your big democratic chance to make change, and then go on to the next house. Because you can waste a lot of time talking to people who aren't going to vote. On that point, I'll stop. Thank you.
Thanks very much, Stan. It makes me think a year ago now I was just about to have my knee replaced, so I had the excuse for not delivering leaflets and knocking on doors. That is no longer with me, so I have shed a bit of weight already in the last few weeks, but that's great. Richard, I've got your hand up. Thank you.
Yeah, thanks, Jonathan. I mean, I would echo Stan's optimistic mood. North and North East Lincolnshire are working well together, and of course we're sharing a Director of Public Health now, and likewise we've all signed up very strongly to the Greater Lincolnshire County devolution deal. I think from a North Lincolnshire perspective, we've got a really strong foundation to work from with outstanding children's services, and of course we've been through the CQC assurance pilot process, and we've come out with a good, we believe. So confidence among our children's services and adult social care is strong. So that's a good place to start from. We're working now down a route of outcome-based budgeting, which is honestly giving us a laser-like focus on what we're here for, what we're about, but I think most importantly about working in an integrated way, both across our organisation and with our partners, and particularly in health. So our integration work is going well. In terms of our outcome-based budgeting, it's really interesting that when you start to focus on your outcomes, if you really look at the key focus of outcomes for residents of North Lincolnshire, it's all around health and well-being. It absolutely is. And that's what makes, you know, the work that we do here at the ICP so critical, because we've already pointed out we're spending 2/3 of our budget on children's services and adult social care, and that suggests that our priorities are right. So yeah, I'd share that optimism with a healthy dose of no complacency either.
Thanks very much, Richard. So I like the South Bank enthusiasm. It's cheered me up no end. Thank you. Thanks very much. Anybody else like to comment or any questions from anybody at this stage? No. Okay, thank you for that. We shall move on then, I think, to the Futures Group report. Charlie isn't with us, but Karina, are you going to sort of take us through that?
Yeah, I am.
Okay, thanks very much.
So there's just two things really to cover today. Stephen's briefly touched on one of them, which was that at the Integrated Care Board last week, a proposal that the Futures Group have been working on was presented, and I'll just explain that a little bit more. The papers were attached for people to read for this meeting as well, but given that the Futures Group does report into here, I will just touch on that a little bit. And then the second one was that we've had a meeting this morning and we're talking about the what next, so I'll just briefly outline some of that as well. So in terms of the proposal, people will hopefully have read the papers that were there, but this is about our establishment of a connected Humber and North Yorkshire, particularly, and it's described in the paragraph 3.1.1 in the paper, about the strategic application of data science alongside professional wisdom and the voice of people in our communities, to enable them to be able to lead to evidence-based integrated service delivery. So that sounds very technical and very grand. I think really at the heart of it is that what we're saying is we want people to be able to use data, and those professional people, whether they're care professionals, education providers, whether they're voluntary and community sector, along with the people who live in those and are the receivers of services, can work together to deliver and change how we deliver services on the ground and drive better outcomes for them. At the heart of this, there's a lot of work has gone into considering how we would achieve some of that, and there is a more technical angle to this that we've talked about in terms of how we would gather that data and the creation of a what is acronymed as IDEA, so an integrated approach, integrated data engine for analytics, which is where the tool through which we would connect the data. Namely, we're not doing this from scratch. We are building on work that has been done elsewhere. So we've been connecting with Bradford on their Connected Bradford programme and what they're already doing, and we have started to do, which is implement a programme called Born and Bred In. So there is some basis for us to start this work. There are a number of proposals that we've set out in terms of the next steps, and we talked a little bit more about that this morning when the Futures Group met, just to talk through how we drive this forward now that the Integrated Care Board kindly supported the proposal and have given us a small amount of funding to help fund that. And the key focus of that will be establishing a further business case that details this approach in more detail, also looks at the return on investment so that we're really clear about what we're going to do in terms of return on investment. That will be done by potentially through trying to implement this in small geographies within a couple of our places so that we can test it as use cases to give us some of the evidence. And we will have the support, as we have all the way through the development of this, from our academic partners who have been front and central to the work that we've done to date. So there's further work to do around that proposal and building it into something that actually will be quite trailblazing. We have a national reference group set up as well. They meet for the first time next week on the back of the decisions that we've taken, so they can provide us some steer, but also helpfully unblock any of the issues that we might experience if we experience them from a national perspective, especially when it comes to linking data. So I think there is a lot to do, but I think it's great. We got a lot of support from the Integrated Care Board. They were, in fact, I didn't actually have to speak at the meeting, which was a real testament to the work that the team who have been working on this have put into trying to make sure it was well received. And thanks goes to all of them, and to particularly Mark Mon-Williams, who has been an academic support to this, that if we hadn't had, probably we wouldn't have got as far as we've got. So that's all I probably want to say on that, and I don't know if anybody's got any questions really at this point in relation to that.
Thanks, Green. Can I echo your comments from the ICB last week, or whenever it was, the positive vibes across the room, across all partners in the system for supporting this work moving forward. And I remember Stephen saying, you know, the contribution we're making as a percentage of the budget was so minuscule it was hardly worth debating. So I think that will be money will be exceedingly well spent moving forwards. And it's quite refreshing, I think, to have that academic input, because I know I've got York University, but Hull University as well. They're very active in terms of working, looking to across systems moving to the future. So those links are great, I think, and a step forward away from where we've been in the past. But any questions for Karina on the Futures programme? No? Okay, we are rattling on at a rate of knots here, yes. So I'm now going to move to Alex for Chief Operating Officer Place Report, so you can maybe bring us back on track time-wise now.
Right.
Over to you, Alex.
Thank you, Chair. Okay, thank you. I will take the report as read, but I will pick a few key issues out of the report as well. So each of our places has a really strong connection with their local partners, statutory, volunteer, community sector and wider partnerships, which are key in looking at how we deliver those improved outcomes around our place, health, wellbeing priorities, and through our place operating arrangements. And just a quick recap, of course, the priorities for our places are around delivering integration and service transformation, in line with those place priorities and within our joint forward plan and our local health and wellbeing priorities as well, and leading and assuring that mutual responsibility and accountability at place for deliverables in our operational plan. And I'll talk about some of the key focus areas that we've been looking at in relation to that. And then, of course, in line with the conversations we've just been having, really driving that quality and productivity and agenda. So place central to taking forward the agenda in regard to that as well. So the role of place is firmly embedded across all of our structures and ways of working, and as part of the work that we've been doing, which I'll touch on later on the agenda, of the further evolution of our operating model, we've been developing a shared framework that demonstrates where place will really drive that improvement, that premium, and where place can really deliver that unique additional advantage as well. But I will come back to that in a little bit more detail, and some of the discussions that we've had this morning about the development of that shared framework and the next steps and where that will take us, and how that really starts to drive the triple aim that we've got around better health and wellbeing, reducing health inequalities and improved outcomes as well. So in terms of some of the key operational delivery priorities that we touched on at the beginning of the meeting, we've got key programmes of work in place, but we've also got some really strong collective working happening across our places to drive this agenda. So particularly focusing on some of the challenges that we've seen over winter in relation to urgent care, discharge, patient flow, and some of those urgent and emergency care pressures. So a really connected piece of work driving how we do that, how we deliver that, and how we support that system escalation response. Community engagement, prevention, how we manage some of the demand pressures that we're seeing already and continuing to see across our populations, and how we work collectively to do that with a real focus around inequalities and some of our more vulnerable population groups within that. Looking at our integrated community offer, so how we make sure we've got really strong connections and solutions in community. So as we heard members mention earlier about how we support people home first, really driving that care within the community and avoiding the need for hospital admissions wherever possible. Work around some of our individuals, adults and children with the really complex needs as well. So we've got complex case management. Some of the people we heard earlier about who are putting some pressures in our system, both in terms of their needs, demand and costs, and how do we do that in a way that uses our resources as effectively as possible but gets the best outcomes for people as close to home as possible. Primary care transformation and the development of integrated neighbourhood teams. We've got some really good examples now emerging across the integrated care system. We're now looking at how do we really systematise that approach to delivery of integrated neighbourhood teams driven through a strong population health management approach to support that. And then really connecting in, as I mentioned, to that productivity and efficiency agenda, how we use our resources as effectively as possible to be able to do that. Within the report, and I'm not going to go into these in detail, but it's, I think, useful to get a flavour of some of the key things that talk about the needs and speak to the needs of individual places and some of the real initiatives that we've started to see in line with those priority areas as well across the spectrum of prevention, community as well. So you can see we've got some great examples in our places where we've started to develop some of those models of care and really start to make a difference right across the spectrum of the life course to support that as well. Place obviously is part of the wider system and collects really closely with our sector collaboratives to make sure we've got that really strong connected working to support that as well, and uses a matrix-based approach to make sure that we deliver that transformation and integration in an effective way as well. And we've also been working recently very closely around planning as well, with the planning agenda driven through places, coordinated with the rest of the system, so that we have been able to deliver the planning objectives that we've touched on earlier in the meeting as well, and have a really strong connection with place in relation to that. Also, just as well to comment, we've got the Joint Forward Plan refresh, which is going on at the moment. That will be aligning closely to the strategy that you're going to hear about later on in the agenda, and making sure we're really connecting that to the conditions for success in terms of excellence, prevention and sustainability. And we will be working with health and wellbeing boards to take that through as well. So to really concentrate on developing those key priorities we've already identified. And we've already got ongoing relationships and conversations going on about the JFP in relation to health and wellbeing boards. So the next steps and priorities going forward are the further development of the framework, which I'll talk about later on in the agenda. Places are also, as a result of the work that we've done in that, I think has really energised places to start to look at where they want to go further in terms of governance and accountability arrangements as well. So there is work ongoing to consider options for further joint committees or expanded pooled budget arrangements as well. I've already mentioned really strong connection into the work that we are doing around quality, efficiency and productivity. And then really good connection to planning. And then just a comment, and probably just ask Helen if she wants to add anything to this, which has already been mentioned, I think, by Star and Councillor Shreve as well, the Section 75 agreement, which was signed off at the ICB board last week as well. So that concludes my points. Helen, I don't know if there's anything you want to add in relation to that?
Yeah, I think it's probably worth noting that obviously North East Lincolnshire has been working as a health and care system for a long time, so this is not a new document. It's an amendment to a pre-existing arrangement that we got in place. Nevertheless, it has occupied a lot of our time, making sure that it's working right and it's got the right connections now within the context of the ICB, the 6 places and the 5 collaboratives. But I think everybody in North East Lincolnshire, and I know across the ICB, is now at a point where we're wanting to say, okay, what is it actually going to do now? How do we start to move forward and really get on with the business end of what this enables us to do? And I mentioned to Sarah earlier that in actual fact what this actually feels like as a Section 75 is effectively a marriage. It's a long-term commitment to each other that means we'll stand by each other when the chips are down, effectively, through good times and bad. And that perhaps sounds a bit soppy, but actually I think it's a really important principle that we're in this together. But in terms of some of those outcomes that we're hoping to achieve, there's a really strong focus on prevention and well-being, taking that whole system approach to planning, so not looking at things in silos, trying to look at the collective whole, making sure we're joining services together where it makes sense to do so that they're positively impacting to maximum effect on health and well-being. Maximising our funding opportunities between us, actually by working together, and in fact with our broader partners, including VCSE, etc. How are we maximising the total amount of resource that we can make available to our population and to our place to drive the changes that we need to do, and making sure that we're looking at integrating wherever there are opportunities to do so, to make services much more seamless for service users and their families who are having to interact with them. There's a number of other aims and outcomes, but I just think those are really key ones for us to think about as we move forward, and actually start us to focus on how do we improve health rather than spending all of our resources on managing ill health. So I think for us, I think that's a really big focus. We've got our last designate joint committee meeting tomorrow afternoon, and then from 1st of April we'll be moving into the formal arrangements and starting to really get into making those differences for our local population.
Thanks very much. I've noticed Joe's hand up, so we will try the sound system. But while you're speaking, John, I'm just wondering if the other place directors, anyone wants to chip in at all, because it's the only opportunity I get when all the 6 directors are in a room together, you know. And thanks, Alex, being the spokesperson for all. But I'm just wondering if there's any points they'd like to raise in this section. But I'll bring Joe in first. Joe, hi.
I think it will work now. I was on my phone
that's
before,
fine.
which is why it wasn't working. Sorry about that. And apologies for not being there in person. I've got my Health and Wellbeing Board at 4:30. I just wanted to pick up on the point that was just being made about kind of funding opportunities and making best use of efficiencies in the system and that kind of thing. Just wanted to share a couple of things I've picked up from the voluntary sector in particular that I just thought it might be useful for people to reflect on. And one of those that I thought was particularly pertinent was just about health colleagues being kind of aware and cognizant of the different way in which they might procure and supply services compared to the voluntary sector, particularly around security of employment. I know that in York we have lost some staff from the voluntary sector because funding opportunities weren't confirmed in time, and people are pretty much annually put on notice of redundancy, and therefore they look for work and then leave. So we kind of lose some expertise in the system if we can't deliver some continuity of availability of funding, which I think is probably just something to be aware about, just in terms of ensuring we don't make things more inefficient by trying to work in partnership. And just again around things like carers and how carers feel about those relationships. And again, I just think the protocols that we use in the way in which we kind of work in partnership probably just needs to be as much from their point of view as it is from a health point of view. And I suppose that's my plea, I suppose, is can people think about things from both sides and not just from a health side when they're thinking about partnerships? Does that make sense?
Yeah, thanks, Joe. Yes, and I think this is the right forum to actually raise those issues, actually, because maybe the ICB is a bit distant at times from, whereas the people in the room here, I think, understand fully some of the comments you're making. And I know the number of times, I can only speak anecdotally, that, you know, we're suddenly renewing contracts when they've only got weeks to go instead of planning, you know, a year ahead. Point, you know, really well made, I think. Peter.
Thank you, Chair. And Joe, to give you some reassurance, we have the chair of the VCS collaborative in focus at the next Leaders Forum, where we'll be exploring where we can go further with the VCS collaborative. So I think we've got a vehicle to start this conversation.
Okay, thank you. Thanks for that, Joe, and I think everybody's taken on board those comments. Thank you very much. Simon, did you want to?
Well, just following on from that, really, just as we've been doing work across Hull and East Riding in relation to the re-specification of community services, and those contracts, although the majority of them are NHS funded, there is also involvement from Hull City Council in terms of sexual health services, and the longer-term plan will be also to explore opportunities where we can involve East Riding Council as well. So I think that's how we probably should be approaching more about common procurement and common commissioning.
Is that a waving pen, Stephen?
It was a waving pen.
Yes.
Sorry, it was a bit sort of a wishy-washy waving pen. Yeah, just coming back to what Joe was saying, because I think what's going on there, which happens, and you alluded to it actually, Chair, but it's this sort of year-end, you know, decision-making year by year. We are, and it links to Peter's point, we are shifting that, but more immediately, I think this links to the. So let's take North East Links, where we're extending and devolving our account. I think it should be up to North East Links to decide which contracts it operates with in the voluntary sector, and where it wants to see the voluntary sector priorities be, rather than some contracting department in the ICB. So I think we're between those two places, Joe. So because it might be appropriate for some contracts to end, some to be expanded and extended, and some new ones to be set within a finite resource. Now, place directors can talk about that issue locally, but that's how it should be. I don't think it should be. Now, the voluntary sector collaborative is about trying to do what all of our collaboratives are doing, which is to where should we be aligning some things in the voluntary sector with the overall system. The obvious place in relation to that, to me, is in terms of our workforce strategies, because they're a really, really important workforce, and probably increasingly important. So I'm sure what you're describing has happened, but that's where we want to get to, and I think that the place has got a really significant, after all, in every place, as far as I know it, there's a voluntary sector assembly. The whole point of voluntary sector assembly is for someone to sit on the place board and for these things to be worked out. So I just wanted to emphasise that point, if that's okay. Thank you.
Thank you. Any other comments from anybody? No? Okay, well, thanks very much, Alex, for that. Yeah, sorry. Eric.
No, that's all right. No, I was just going to add to that. It's a real opportunity, and we have progressed some of that in Hull, and I hear what Joe was saying in terms of previously, particularly in the city, we did have sort of short-term grant type arrangements with the voluntary sector, and we've moved away from that. So we jointly discuss all those and look to wherever possible, that being a much more sustainable and longer-term contracting process, which we do together. So there's absolutely substantial opportunities in working in that way. And it's something that we have adopted, and I know other places have adopted as well, but it's a real opportunity for places. We absolutely should have the handle on it, I think.
Thank you. It's always refreshing to see when any place director speaks, the other five nodding their heads in agreement. So it gives you the sense that you are working together, which I think is brilliant. So thank you very much for that. Okay. So again, thanks, Alex, and I'll hand over to Sue, I think, at this point for
thank you,
next
Jonathan.
item. Yeah.
It's lovely to share the load with you. Let's move on to item 11. This is the partnership strategy recast. I'm going to look to both Karina and Pete for this one. So over to whichever one of you is kicking off.
Me.
You.
Thanks, Sue. In terms of the of the integrated care strategy, many people, although I recognise there are some new faces around the table, will know that just over 12 months ago we signed off our first ever integrated care system strategy. At the time when we signed that off, we were really sensitive to the context that we were operating in. We were a new integrated care board. We'd brought 6 clinical commissioning groups together. We were still trying to find how our arrangements, albeit we've always had very strong arrangements in relation to our working with local government, in place, particularly, as we've heard. But we were really clear about that. So we took a really purposeful decision to build the integrated care strategy from the ground up. And we had a lot of engagement with places, with communities, with a cross-section of different stakeholders at that time. But the strategy itself it was really comprehensive and inclusive. It described the complexity of the system that we were working in at that point in time, and probably showed too much of our workings out rather than really our ambition, our clear ambition and our transformation that we wanted to take everyone. Having said that, it was approved by the ICB itself and by all of the 6 health and wellbeing boards, which is an achievement in itself as well. If I could have the next slide, please. So over the course of the last 6 months or so, through work with the System Leaders Forum and, as you'll hear later, with a lot of other stakeholders, we've come to realise that wouldn't it be even better if we acknowledge some of the following. So our context has absolutely moved on. We've been hearing a lot about the maturity of the system and how the arrangements and ways of working with place and the collaboratives are changing, and how that trust and understanding is building. As I've said, we don't really need to show all our workings out now because of that, and so the destination needed to be described in a better way, a bit clearer, so that we can see how we're going to get there, really. And it means that we can be really clear to make sure that not everything is going to be a priority, but also recognise that we need to put pace behind what we're doing to be able to realise our shared ambition. And I'll hand over to Pete.
Thanks, Karina. Give the next slide, please, Mike. Thank you. So, just to be clear, this is not an exercise in shuffling bits of paper and coming up with new pieces of paper. This is the purpose of this work is to unlock the operating model. So we've heard this in parts today, but just to set the scene for that. The operating model that we have, 5 collaboratives, the 6 local authority places, and then there's the if you like, the core of the ICB, the organisation that is the ICB itself. And that operating model has got to drive the greatest impact for the people that we are here to serve possible. So this is, if you like, the process that we've been through to get to the next pieces of paper, but it's not about the piece of paper. So we've been doing a lot of work, as you've heard, around understanding what does system maturity really look like and what does it feel like, what are the behaviours we would be seeing within that, what would our appetite towards risk look like in that space, and really moving into a much more distributed leadership model than we've had previously. At the same time, going back into the strategy allows us to lift ambition. And I'll just describe how some of that ambition has started to change now in the way we're thinking. As it says on as Karina's alluded to, this frame has been on a journey of socialisation. I'm almost bored of seeing it now, but it needs, because we kind of need to end the socialisation. But what it has done is, because it's cut through the priorities. It's allowed us to see the wood for the trees. We're picking up the pace much quicker now with the things which we think will make the most difference. So if we're comfortable with that sense of what do we mean by unlocking the operating model, I'll just get us into some of the detail then. So the next slide, please, Mike. So the overarching aim that we signed up for in the strategy of narrowing the gap in health life expectancy and increasing can't get my words out, healthy life expectancy by 5 years, those remain. We've started to iterate some of our language, so we've talked a lot about start well, live well, age well, die well. Those life stages are our outcomes. So when we're talking about an outcome-led approach, we're talking about making sure that those 4 are achieved. The ambitions have been slightly reworded to lift them higher. Health and care equity, I think we would all sign up for, and transforming people's health and care experiences. But what's new at that top line is radically improving children's wellbeing, health and care has now shifted to the top line of our ambition. So that is the difference. So we're talking there about the generational change in outcomes for children, which will clearly be part of increasing longevity way past the time when we're not sat around this table. In the original strategy, there was a set of intents called think person, think family, think community. They kind of floated a little bit. By going through the iteration, we know that they are our person-centred and strength-based approach. They speak strongly to the language of social care, and they help us in some of maybe thinking around how we demedicalise some of our approaches. So you think about mental health and so on and so forth. So that's it's kind of the simplify at the top line. If we just go a little bit, next one please. What we have done is go into the public health data to ask the question of what would be the 4 things which would make the most difference for this system. So that's not to say that everything else isn't important. So if you do need your knee doing, if you're the person who needs your knee doing, you really do need your knee doing. But if we could reduce harm from cancer, if we cut cardiovascular disease, if we supported people to live with frailty and enabled mental health and resilience, and you know, just note the language there, this is not a deficit model, you know, mental health resilience. These are the things which would make a significant difference in our top line ambition. Now there's a question for this partnership of, so what would that mean for us if we're shining a light? What is our line of sight going to be? And I think we maybe want to think about that as we develop this further forward. The next one, please, Mike. And then to take Karina's point that the strategy had a lot of destination, less engine underneath the bonnet of how we're going to get there. Through the work with the Leaders Forum, we've settled on 10 drivers which we would say these are the things we're going to invest in. So you can see how they're grouped up under excellence, prevention and sustainability, which Alex referenced. Those are the lenses by which we are challenging everything that we do to see if they meet those 3 tests, if you like, and at the same time putting voice at the heart. So I'm not going to read through these, but I will just pick out a couple. The outcome-led resourcing, I think we've already heard an allusion to why that's powerful today. We've heard about the Connected Humber and North Yorkshire project, which picks digital and data and connects that to children. We've heard about the work around place direction. So the work that fits into this is now starting to form up. We recognise that we will have to have an absolutely different approach towards public engagement. The way in which people access their health and care is going to be different in 5 years, different in 10 years. And I think we have a duty to prepare the public for how that will be. So, for example, in the introduction of technology, what does technology look like if you live in a rural area, for example, if you're ageing? And then the 10th one is probably worth picking up as well, is collectively we do have a very powerful voice, and we should not be afraid to use that voice both professionally and politically to help drive policy change and be a supportive voice, but maybe challenging to Whitehall on our thinking. So that starts to form up and that's not all the detail, obviously. Those boxes, the 10 need to be populated. But that forms our frame for saying we'll invest in these things and we'll only invest if they meet those criteria. And then, next one please, Mike. Popping it all together, that's how it comes together. So it's on a page. It's been remarkably resilient on its journey of socialisation. I think probably the only line in there is the think person, think family, think community, where it's a bit about, does that belong on this page, or is that an approach that we pop in the back end of the strategy? Welcome to have opinions on that. But there is a narrow simplicity, and just to kind of illustrate what that means, so in radically improving children's wellbeing, health and care, by magic, we now have an ICP Children's Board, which is pulling together quite a lot of the that health and care input. Directors of Children's Services met last week with a couple of members of the executive to start to unpick what that relationship looks like, and so we start to build some energy behind this. And then some other examples, if you just click it again please, Mike. The Leaders Forum has been picking out, particularly in the last couple of months, the empowering collaboratives, the new relationship with place, which we've touched on. We're into the third year of our breakthrough plan for workforce, and that outcomes-led resourcing, that searing focus on, is what we're investing in going to deliver an outcome for the people we're here for, has led to some really interesting work with Grant Thornton around sizing the prize on 10 very significant pieces of work we could do to then start to build that system sustainability that you heard about from Stephen in the first place. So that's what it looks like. And the next one is, so what's that mean for the ICB as an organisation? So this phrase, a smaller ICB within a flourishing system, was coined at the Leaders Forum. And if we get it right in our subsidiarity, if we let go to place, if we let go to collaboratives, if we renegotiate the accountability and assurance back properly, the ICB will become part of that smaller workforce, which has to be smaller across the entire NHS if we are to hit the productivity requirements. So that means doing only what the ICB can do because of its scale and position, and the things which we are mandated to do, such as we do have a role in intervening if there is service failure, for example. And then that takes the ICB into its own organisational development cycle again. So I'll pause for any questions, but otherwise I'm going to hand to Karina, who will say where we go next with this.
Yeah, Helen first, then Stan.
Yeah, it's not a question. I think it's answering your query in relation to, do we think the think person, think family, think community should be on that page or not? I really strongly think it should be, because otherwise we potentially lose the focus of what we're actually all about, which is people and people's health. It sort of can lose some of the personalisation if we don't have it on there. And I think the bit about thinking about the person, recognising that they're not in isolation, and whatever the impact is for the individual, it then also springs out into the family, and that can be positive as well as negative. So actually, how are we harnessing that to get change? And actually, families are part of communities, and by engaging with families, how are we then making sure that we're starting that change process with communities as well? So from my perspective, I think it's really important that stays on the list.
Thanks, Helen. Your opportunity to contribute. Stan?
Well, a couple of points, really. For me, there was an hallelujah moment in your presentation, and that was when you said we delved into the public health data. About bloody time that we did that. I mean, Public Health Observatory is very rich in information, and it's about time that we use it to drive our outcomes, and I think that is a really strong piece of message there. The second thing I'll say is, building on what Helen just said, I attended for the second time yesterday an event in North East Lincolnshire on co-production. Right, co-production is where a sophisticated, mature organisation realises, as the ICB is realising, that it's not them that does it. Yeah? Co-production is about the voice of the customer, the voice of the person, the voice of the society. And I think as we become more sophisticated and accepting of our strategy, that voice will be how we do things going forward. And last year I used the expression doing to rather than doing by. And we're moving from the doing to into the doing by, and the doing by is informed by great co-production. So we have to find a way. It's in there, but it's not explicitly in there, and I think we do need to find a way of including it. Thank you.
Thank you, Stan. I can see that Richard's got his hand up twice, and Joe's got hers at once. So we'll go Richard, then Joe, please. Richard Hannigan.
Yeah, thanks, Phil. I'm not sure I've got my hand up twice, but that's technology for you.
This is the way around. It was Joe first and then Richard.
Oh, never mind.
I think it was. I'm perfectly happy to let Joe go first.
No, I think we'll just keep going.
No, go.
Okay, that's fine. I can sign up to this strategy, and it's great to see it on a page, and good to see you, Peter, so thank you for that. I agree. I think that think person, think family and think community is really critical, because let's be honest, that's what we're all about. That's where we focus. I suppose for me, the challenge really about this is, how are we going to manage performance? Because performance is everything in this. We're starting to form around some very clear outcomes. We can't be managing, I don't think, just on budget. We've got to manage our biggest and most important resources, which is our people. And I wonder if perhaps Karina's going to cover that in the next phase, I don't know. But I think that's the next place we have to look to see how we are progressing towards our outcomes and how we manage our performance in the short and longer term.
Thank you. And Joe?
Thank you. Just a small point about points 9 and 10 on that slide around public engagement and system voices. It says voice at the heart, and I completely agree with that. It was really just to ask what that looks like, how it's done, because I think one of the things that I think is really challenging for everyone in this space really is when things are difficult on the ground, and for professionals and for patients, how you ensure that engagement is both meaningful but also realistic or respectful on both sides. I think that's really hard, and so I guess I'm saying yes, it's really good to have it there. I think it's a really difficult thing to do, and I think for health colleagues in particular, that is quite challenging when things are difficult, and they're very busy, understandably, doing the what. That it is important that they don't forget the why to the people at the other end of it, which I'm sure they don't. But actually, transformative public engagement would be about making sure that listening to those people and responding to what they're saying is really at the heart of how we're operating.
Thank you, Joe. That's great. Wendy?
I'd written down the word meaningful, Joe, so I think there's something around.
Yeah.
We might just want to say I know voice of the heart feels like it's sort of very widely understood, but I think there is something about meaningful or purposeful, isn't there, in that context. I'm also keen that we sort of continue to reflect. Sorry, my slides are flipping about, but they sort of think person, think family, think community. Only because I know when we started to do the work on the strategy, there were lots of the places were also starting to do work around their health and wellbeing board strategies. We, particularly in North Yorkshire, are out to consultation on the health and wellbeing board strategy at the moment, and we have very much taken the basis of this work so that we've got the golden thread flowing through from ICP through to place, and think person, think family, think community are central tenets of the strategy that we're consulting on at the moment. I think there's something, and again we might get into this conversation, but I think it's really pleasing to see that we're sort of getting into the how. There's probably still something, isn't there, about if these are going to be the priorities, particularly the 4 priorities that I recognise from the ICB that we're going to focus on. Are we as clear about the things that we might have to stop doing? And at some stage, that's probably sort of one of those wicked issues that we might need to get into to think and understand what the impact of stopping some things would have in the context of absolutely moving forward at pace in terms of delivering this strategy.
Yeah, it's a good point, good to remind us. All done? Helen, is that...
Yeah, I suppose also picking up on that voice at the heart, and I think there's building on Councillor Shrew's point around the co-production, and in particular how are we working with people with lived experience, and ensuring that we're relating and communicating with and working with people from all different demographics. I know I was in a recent meeting where somebody said, well, you know, the people in one of our more deprived wards are not retired solicitors, accountants, etc. You know, they can't give their time in the same way as perhaps some of the more affluent areas of our population do. So actually, how do we enable people to properly get engaged in the work that we're doing going forward, and whether that's young mums, providing them with childcare, a creche facility to enable them to get involved. I just think there's something for us as an ICP to think, if we're serious about getting that voice at the heart, how are we actually enabling those people that we probably need to speak to the most to properly get engaged with us?
Yeah. It's a challenge across the Integrated Care Board. We puzzle about the same thing. How do you get that voice of lived experience to influence the work of the board, just as we do here? And it's absolutely on our list, really, of work that we need to do. So meaningful is an important word, and actually making that work is really critical. Jonathan.
Yeah, it's just a reflection, really. It's funny how things start to fall into place. I mean, it's taken maybe 18 months, but suddenly, you know, I've spent years trying to explain revenue and capital to residents and council tax. That I can actually use and describe, I think, to, I wouldn't say every man and woman in the street, but it's a really good start, and somehow it clears your mind a bit as to what we're about and where we're heading to. So I think it's a great bit of work. And as long as we can put it into practice, it's those outcomes. I think it's back to performance and measurement we talked about earlier. So we know what we're measuring. Oh, yeah. We can talk about those outcomes as well. So I find that quite refreshing. Thank you.
Thank you. Thanks for your comments.
Richard, I think.
Oh, Richard. Sorry, Richard. Oh, and Linda.
Yeah, just one last short point about transformative public engagement. I think engagement is the right word. Absolutely it is. And I wonder if we should define transformative public engagement. Because when you look at health and well-being in particular, it's exceptionally emotive. And often the timing of when you engage is really important to try and lower the levels of emotion. Because what you'll often get is opinion. What you're really looking for is informed views, aren't you? So as well as enabling people to participate in the process, I think you've also got to work with people so that there's a greater understanding of what's going on in the system around them at all the appropriate levels, so that when you engage, you get informed views and not just opinion that's driven by emotion. So maybe if we define transformative public engagement, that might help.
Thank you.
Just to say that in Hull we've been doing engagement with residents around a community plan, where everything revolves around, we've asked them what they find important. So health and council and our partners are all working towards what their main objectives are.
Yeah. Fits really well with the...
Yeah, just sit with this.
And Karina.
Yeah, so I think there's a couple of slides at the end. I won't go through them, but in terms of responding to Councillor Hannigan particularly, obviously Jake's going to take us through the outcomes framework in a minute that will sit alongside this, that will help with some of the measurement of how we're doing. In the fast-paced world that we're moving in as well at the moment, there has been work going on through the System Leaders Forum about some of the activities and the specifics of the detail that will sit alongside those 10 drivers, and how we get oversight of all of that, and thinking through that, and then particularly on the last point that that Councillor Hannigan made in relation to that the sort of voice being used to inform, and rather than that emotion and peace, that's absolutely about the bit that I was talking about earlier in relation to the futures, the connected Humber and North Yorkshire. If we can get that information in the right way out to the practitioners and out to the people, families and communities that we've got, then that takes some of the emotion out of it, and we can have those real important conversations to engage with people.
Lovely, thank you. Thank you all very much indeed. Good slides. Shall we move on to item 12? I think this is you.
It is.
Is it? Please, thank you.
Chair, I mean, not to be slightly pedantic, but just picking up the point about this is the last point of socialisation.
Yes,
I think it's probably just helpful to, at least I mean, I think it's obvious from the conversation, but just formally endorse what's being presented. I mean, it will be, I think we can pick up there's a number of important points like meaningful, for example, and some of the things that Joe and Stan and others were talking about that we need to sort of build in, but with those assumptions I wonder whether we could just...
Yes, it does say can we recommit to it on the agenda. Sorry I've missed that. Can we recommit? I'm looking for some nodding heads. I'm looking on the screen for some nodding heads as well. Great. So we do recommit. Karina. There we are. Okay, sorry. Jake.
Okay, thank you. Thanks, Chair. So, as Karina said, one of the commitments we made in the strategy originally was that we would look at how we establish a framework for how we measure whether we've succeeded on delivering against the outcomes and the priorities and ambitions that we've set. So, we've been looking at this in the context of the lift and simplified strategy framework. To do these at the same time that we've just been discussing, and for me, there's so much data out there. There's so many outcomes measures. There's so many indicators. There are, as you said, a number of outcomes frameworks for health and wellbeing strategies locally. We have far too many performance measures across the ICB that we're reporting on a monthly basis. There are all sorts of reporting frameworks within our own organisation. So I think that the task with this is to see if we could set something up that gives us a very high level set of outcome measures we can track over time that give us enough of an overview to understand how we're doing, but then with the ability to go in and understand it more in depth when we need to, because there's the granularity, geographically, subject specific, age specific, which communities we're interested in, is all really important. And I think the key thing from my perspective is that people can see the connection. They can see how what they're doing, whether they're working in an integrated neighbourhood team on coronary heart disease or with children in a local authority, how is that going to contribute against a set of high-level outcomes and ambitions that we've agreed and set ourselves as a partnership. So lots of different ways you can cut this, and this is a sort of proposed way of looking at it that we've been trying to populate as a starter at the moment, and we've chosen to build this around our overall aim, which, as people will remember, is around reducing the gap in healthy life expectancy and improving healthy life expectancy overall. The big priorities that Pete and Karina talked about in the previous session, our shared outcomes built around life course, so start well, live well, age well, die well, and then not forgetting all of the things that sit underneath there, things that we've committed to do through our joint forward plan, through our collaborative ambitions, through our place strategies, health and wellbeing boards, etc. For the framework, the proposal is that we focus on those top three elements but show how it connects into the rest of it, so we don't try and present everything in one go. So we're looking at a set of measures that cover overall aim, big priorities, and as I'll come on to, a kind of basket approach around each of the life course framing elements that we've identified. So we'll track life expectancy and track healthy life expectancy at system and place level. we're looking to agree a set of high-level outcomes, probably only 4 or 5 for each of those big priorities. And I've got an example of the kind of things you might use for cutting cardiovascular disease, but I think we can frame these around what we've said. We need to have a conversation around what we're going to try and do within reducing deaths from cancer and living with frailty, etc. So we can flex those as needed. And then, as I said, a wider basket of indicators grouped around life course, and really importantly, being able to... sorry, I'm forgetting to do both fingers on my screen. Right, I'll catch up. There we go. Yeah. So really importantly, showing the alignments between what we're doing here and what's been set at place level. What exists in things like the Core 20 Plus for adults and for children, what we're having to do through our NHS report, what exists in performance outcome frameworks for local authorities in social care or in other areas. We've started at this point on the basis of only selecting indicators which are published nationally in the public domain, where we have available benchmarks and that we can then use in all sorts of different reporting. As colleagues will know, that comes with limitations in that they're updated less frequently, but they are robust and able to be, like I say, really importantly, benchmarked against not just averages, but against similar areas to our places and our ICB, our ICS. We're also using this as a vehicle for collaboration with our local authority public health colleagues as well. It's in the population health space, and we're trying to use shared capacity to start to populate the outcomes, both at scale and then, really importantly, to be able to then replicate those at very granular levels. So you can look, if you need to, at how you're doing against these high-level measures at sub-place level, neighbourhood, electoral ward, super output areas. And critically within all of this, and as we've said in the strategy, the ability to cut any and all of this by inequalities dimensions to look at outcomes for our disadvantaged communities is going to be absolutely critical where that's available. And as people know, there are gaps on what we can currently do, but there's quite a lot we can do, particularly around deprived communities in the main. And as I said, really important to make that connection between what we're looking at a high level and how that's tracking and how you will deliver those through commitments that you set through our joint forward plans, through our place strategies, place commitments, and how they would contribute in a kind of logic modelling sort of approach. What are the things that we would do here that are likely to impact further down the line on this longer term outcome that we've set? And as I said, there's going to be no end of supporting dashboards and reports for any of the themes and programmes, but I'm really keen that we use this as a mechanism for helping people interact with the data and in a bit more of a narrative way. So if I start here, if I start with living with frailty, is it easy for me then to go in and see, so if that's what we're aiming at, what are the things that are going to contribute, what's happening in my community, what's happening at this place, what's happening for this specific aspect of care or for this intervention. Just quickly on multitasking. So just as a reflection of the challenges that we've got, so our highest level aim on reducing the gap in healthy life expectancy and increasing healthy life expectancy. I mean, these scatter plots show on the vertical axis change in life expectancy for our places in the last 10 years. And on the Y and on the X-axis, change in healthy life expectancy. And, you know, as with many places in the country, there's just been a huge stalling, and we've had actually quite significant decreases in healthy life expectancy, let alone increasing it by 5 years, 10 years, 5 years, or reducing gaps. So we're in a difficult place on the healthy life expectancy target, as are pretty much all communities in the country, and COVID obviously has significantly intensified that challenge. So, as I said before, as an example, we talked through with some of the cardiovascular disease prevention leads in the ICB, what are the sort of things we might put in as a high-level set of metrics around cardiovascular disease? And again, these can be moved around, changed, but I guess the point I wanted to make with this, that they aren't just about healthcare and about, you know, mortality. There's lifestyle prevention, some of the preventative interventions, smoking prevalence, secondary prevention in primary care. You can look at other things as well to do with obesity, for example. So it's really what are the things we would like to see that would give us a good overview based on the work that we're committing to do as a partnership. And then if I come on to the life course ambitions, so start well, live well, age well, die well, and these are the quotes that we used in the strategy originally. So it was a series of statements based on, you know, what from our population's perspective would the improvements look like in terms of how they reflect, how they the meaning they would have for individuals. So my wishes are known and respected. I can get advice and support for my health at home or nearby. So quite challenging to turn directly into outcomes measures, but we've had a go at sort of looking at the kind of things that reflect those broadly. And again, there's a range of metrics you can use within these sorts of areas that pick up on the sorts of themes that are in there. And we did a mapping right across the 6 places in terms of health and wellbeing outcomes frameworks and plans that colleagues have put in place. So there's quite a lot of overlap, and a number of our places are using the life course approach as well. And even if they're not explicitly, a lot of the same things feature in all of our places. So really good to see the interaction there. And then we also looked at alignment with national outcomes frameworks as well, where there's an evidence base on some of the big priorities, big priority themes for population health improvement. There are, of course, real gaps, and I'll come back to it at the end, but you know, there are things where you know, my background is very much in quantitative data, and we really need to look at how we improve the use of voice of lived experience and qualitative research, community perspectives into how we measure progress, and that's something that I'm really keen to work with Anya and others on going forward. So just a couple of examples around health inequalities, and this is drawn from data that's part of CVD Prevent, which is a big national audit, primary care, which has data from every practice around the country, around a whole range of interventions around reducing cardiovascular disease. And this is on management of hypertension in primary care, and it shows the range between our most and least deprived populations within each of our places. And you can measure that difference. You can look at the gap between the most and the least on a specific target that you've set, and we can track that. And there's quite a lot of variation, as you can see. There's variation both within each of our places, and there's variation, obviously, between our places as well. And quite difficult, and hopefully this isn't too complex or confusing for people, but this is, again, the same data, but for all of the ICBs in the country, and the pink dots are Humber and North Yorkshire ICB, and this just shows another measure which is called the slope index of inequalities, which is something that NHS England are heavily focusing on, and PHE, where I previously worked, did a lot of work in this space as well.
You need to move it on.
Thank you. And it's yes, and it's an aggregate measure of inequality. It's a difference measure between your most and least deprived populations. And what this one shows is on the vertical, it tells you whether overall performance for the ICB has improved, and on the horizontal, what's happened to inequalities. So all of the ICBs in the region have improved in terms of performance, but inequalities are getting wider, and they've got wider for our ICB. So we can track this in quite a numerical way. Again, I'd welcome views on how translatable it is and how useful it is in public discourse, but it's a decent quantifiable measure for how you look at health inequalities, and you can use that across a whole range of different metrics.
Thank you.
So I think, can I just make a comment, Chair, briefly on that, your question about how useful is it? Well, if I understood you correctly, and tell me if I've got this right before I go any further, so we've got the data that can break that down across our system.
Yeah, yeah.
So I would contend that in the challenged financial world that we're in, whether that's in the NHS or in local government or in the voluntary sector, it doesn't matter where it is. And you touched on this a little earlier, something you said. And this is what I think what Richard's driving at. We have to be absolutely as certain as we possibly can that where we invest our resources drives some of that improvement in performance. And my experience, limited experience of this, is quite often it's quite scattergun. It's quite difficult to know whether you've had an impact or not. So I think it's extremely useful from that point of view. Just to, if I may say. And when people talk about the use of data, which we're hearing a lot about yesterday in the national meeting, and of course if you're going to drive into territory on productivity in this arena, which is one of the buckets they're looking at, even more important. Actually, so how you then translate that comes back to Joe's, other people's challenges about, well, how you then sort of make that meaningful to the public, I think is then something else you have to do on top of that. But I think in terms of how we target limited resources, it's really, really important.
Yeah. Thank you, Steve.
Absolutely, and that very much plays into the population health management approach that we're trying to roll out through all of our systems.
Is there one final slide, Jane?
Yes, just was on next steps, which we'd like to use the coming months to just work with place leads, with programme leads and others, just to get the metrics right, and as we get clear on what we want to do within the Big Four, will be really helpful, and just to start to draw the lines between what we're doing around planning and the JFP and how this connects to some of the outcomes, and then we'll carry on work around populating some of the metrics, and like I said, really keen to do some further work around both voice of lived experience and then a point, Sue, you'd made recently around just making this stuff more meaningful for the public, what we can do. And I know from colleagues, I've been talking to a lot of colleagues around the country, everyone's trying to do something similar. Okay. How do you produce stuff that actually has more resonance and impact? That's
great.
It.
Thank you very much indeed. Now let me just check the agenda. We were to agree the next steps, weren't we? That's what we were to do, and I think we've heard those, and I think we are agreed with them. Is there a final comment, Peter?
It was about the outcome measures, and thanks for clarifying. It's still that they're not finalised yet, are they? Just an observation is there's a lot of there are a lot of measures which are attached to the failure end of the business. So under living well, it's almost like the failure bit. Yeah. Whereas if we're trying to get that transformative bit, we'd have some sense of the things which are more holistic in there.
Yeah. I think that's a really good point, Sarah.
Yeah, thank you, Chair. Just a really brief comment, really, in terms of I think how welcomed this is. I think it's a gap that we've been living with for a long time, and I think from a place perspective, this is at the heart of what place is all about. So operating without this, I think, is difficult, clearly, in terms of setting out our, the new relationship with place. And I think I would probably have a similar question to what Pete had in terms of are the measures sort of set, because specifically I'm thinking about the conversations we're having with our sort of social care and communities teams within the local authority, which is very much about strength-based, community-led assets. Had a conversation with our new Director of Adult Social Services yesterday, and that was exactly the conversation we were having around things like reablement services. We are not measuring the sort of strengths-based approaches or rewarding providers for operating in that way. So I would really welcome that perhaps to be further thought through, and I think we could ensure that we've got the right people linked into those conversations before it's finalised.
Perfect. Thank you, Sarah. Okay, I'm going to keep moving us along because time's moving on. Item 13, the place framework. Alex, I think this falls to you.
Thank you, Chair. So just to set a little bit of the context around this, which I did earlier in the meeting. So this is very much builds on the discussion that we've had and what Peter was outlining in terms of the next steps around the evaluation of our operating framework and how we really unlock the potential. So the work that we've been doing in building that new relationship with place is how do we unlock the potential of place, how do we really drive place premium, place outcomes, and our real potential to start to address some of the issues that we've been talking about here in terms of improving outcomes and reducing health inequalities. So the three key bits that I'd just like to pick up in terms of background around this. So we've had some really strong engagement work around the development of a place framework, which I'll touch on in a minute, with our local authority representation, chief executives and our place directors, where we've worked collectively together to build a framework for place that helps us to drive that agenda. And excellent engagement in that, and a really strong conversation this morning, I think, about the role of the framework and how we can use the framework to drive the delivery of our ambitions. The second point I'd like to make is the point that Peter made around maturity, so operating in a mature environment. So how we change the way that we focus on delivery and how we look at working collectively together. We look at peer review processes to really drive that mature operating environment within the place. And then we also have discussed as well looking at the future democratic situation in terms of devolution and mayoral combined authority. So how will the framework link to that? And it provides a really good process to start that conversation about how we really drive forward the ICP and the framework at place. So just a little bit of background on the framework. We've been using the ICS Leadership Forum as an authorising environment to develop this framework, and we're now at a process of final socialisation before sign-off. It really builds around what we need to do together to be successful, so focuses on that golden thread around excellence, prevention and sustainability. So under the excellence, how do we collaborate effectively? How do we look at continuous improvement embedded in everything we do? How do we look at innovation? Under prevention, how do we empower our communities? Very much building on conversations that we've had earlier. Drive equality and equity. And how do we look at driving integration of services? And in sustainability, how do we have a transparent and accountable system? Look at how we share our investments, so how do we move to broader pooled budget arrangements, how do we look at really maximising our governance, looking at the potential of joint committees to drive that, and how we make sure we delegate the responsibilities to the right parts of the system to be able to deliver that as well. And underneath that framework, and we discussed that detail earlier this morning as well, we've got some key deliverable outcomes which describe how place operates, but also how place operates in the context of the rest of the integrated care system. So really positive feedback around that. Next steps are to do that final piece of socialisation with the wider system and then look to sign off, and then we will look at how we really embed this as part of the operating model and driving the changes that we've described earlier to support that as well. We also had a conversation this morning about how this can shape and drive the future direction of the Integrated Care Partnership, and really start to identify those areas where we've got our plans and our priorities at place, but there are things that we would do collectively at an ICP because it really makes sense to do that to drive that wider socio-economic benefit. So those are the areas where we look at major investments, large-scale configuration and service change, and the opportunities that we have around that. Looking at how we can influence upwards, looking at how we can influence across the wider system. So a classic example is the work that Karina outlined earlier around the futures work with children as well. So how do we really connect that right across the system in place in the wider system as well. So final bits of work to just finalise the framework, get that signed off, and then we will be using that to really drive the ambitions that we have identified across our wider system and across our places. Happy to take any questions.
Thank you, Alex. Any questions for Alex? I think we may want to have sight of this at board as well. We'll just see how it develops, won't we? It's really useful. So thank you. Moving on, item 14. I'm going to go straight to Karina. This is our annual report and our terms of reference. No great changes here, I don't think, Karina. This is us accounting for the work that we've done in the course of the year and thinking ahead about our terms of reference and how we may want to make change there. So I'm just going to hand over to you, Karina.
Yeah, thank you, Chair. And you probably really said it all, to be fair, because not much more to add. The terms of reference, particularly for people to acknowledge, are track changed, so you can absolutely see where we're proposing to make some amendments and some clear clarifications which have come from the effectiveness review. There are in the paper a set of questions that people may want to consider in terms of the Integrated Care Partnership Committee. If there are things that people would like to highlight in terms of what they think has gone well, what might have gone less well, what we could do differently, any other key messages people feel that they want to feed back to us. We are in the middle of a process as well with NHS England in terms of providing assurance back to them for their annual assessment. Definitely the Health and Wellbeing Board chairs, I suspect, will be approached for directly from them for comments about the ICB and the ICP. So would welcome people providing those to us as well. If there is anything people feel would be really helpful for us to improve.
Lovely, thank you. Was there anything that occurred to anybody as you were looking through that paper? I think Karina's across it. Thank you very much indeed. I don't think we had any matters of any other business, did we? Nothing anyone wants to raise? In which case, thank you. I'm thinking that this was very information heavy for you today, wasn't it? There was a lot to take in and perhaps not quite enough about the stuff that we're proud of and the things that we care about in terms of our patients. So when we're putting together our next agenda, we'll try and create a different balance. But this was work that we had to do today. So any of you that have found that a bit heavy going, I can understand why you might have done. But next time we'll make sure that we balance our agenda in a slightly different way. So thank you all very much indeed. For those of you who've been here all day, well done, thank you. And yeah, you're free to go your own way. Thank you. Bye-bye.
Thanks, Sue. Bye now. Bye, everybody.